name is Gretchen Ruoff, and I'm a Senior Program Director in the Patient Safety Division of CRICO and CRICO Strategies, which we'll share with you a little bit more about in a moment. And so I'm the moderator, and I also have some content as a practitioner, if you will. So I'll introduce you to my colleagues and then share a bit of information about where we're headed today. So on my left, I have Ellen Varney, who's our Chief Financial Officer for CRICO, and as well as Elizabeth Mort, or Liz Mort, who is the Senior Vice President for Patient Safety and the Chief Quality Officer at Mass General Hospital, which is one of our shareholder organizations. So today, to share with you a little bit about what we'll touch on, for those of you who may not be as familiar with CRICO, we'll share a little bit about our organization, as well as a division called CRICO Strategies, which is where I live, and one that you may be less familiar with, perhaps. And then also some background on Mass General, and the three of us will share with you our experience around the use of risk assessments in the process of acquisition. So we'll share with you some of our thoughts and experiences, and are curious to hear yours around the role of risk assessments perhaps before the deal is done, and also after the ink is perhaps dry. And as well, we'll talk with you about the role of these types of risk assessments, specifically in terms of managing integration after an acquisition has occurred. And we'll share with you this from both the insurer's perspective and the hospital's perspective. We have many shared thoughts and shared concerns, but also different experiences. And so we'll let you in on a bit of that. And then we'll open it up for some discussion and some questions. We hope that you're engaged and are eager to carry on a conversation. But some of the things that we'll touch on specifically is the role of culture and the role of culture in impacting our strategy. And as we all know, culture can eat strategy for lunch. And so we have all seen and felt that, and we'll talk about our experiences there. And then we'll talk about our experiences specifically around using this information from risk assessments to impact Mass General's experience in terms of moving forward with integration after acquisition. So a little bit about CRICO, for those of you who aren't as familiar. So we're a captive insurer that cares for the Harvard medical community. We're based in Boston, and for 40 years we have been coding and analyzing the cases that come through to us, and really trying to understand the clinical and legal and system elements that drive the cases that come our way. And as our former CEO used to say, we're a patient safety company that does insurance. And ultimately, when I share with people what I do, I say, our work ultimately is to try and put ourselves out of business. Although I probably shouldn't say that to insurance folks. But to the patient safety people, that usually resonates. But we have been using the data to really identify where the challenges are in our insured organizations, and then develop interventions and programs to try and address those, really with a data-driven approach. And so within our member base, we have 25 hospitals and then another 300 or so additional healthcare organizations. We insure all of the providers, so over 13,000 physicians, as well as all of the residents and fellows, which are a few thousand, and then all of the employees and staff as well, so about 100,000 additional employees. And then CRICO Strategies is a division of CRICO that faces both externally and internally. And we were developed about 20 years ago as a way to answer the need that people brought to us, hoping that CRICO could provide to them the same kind of insights that CRICO provides to its own insureds. So data, analytics, risk assessment, consulting, the things that we have long done for our insureds, folks started coming hoping we could do the same for them. And so through a business relationship, we've been able to develop relationships with organizations across the country that does a couple of things. Certainly it extends some of these insights to a community that wouldn't otherwise have data available to them the way that CRICO does, but it also allows us to bring this information from the nationwide perspective on risk and risk mitigation efforts back to our CRICO insureds. And so we have been conducting risk assessments and providing data-driven insights both internally and externally for several years now. And that extended community includes another 400 or so hospitals and a few 100,000 physicians as well. And together, we bring all of this information into what we call a community of learning. They happen to live in a database, but what we really focus on is the fact that we can connect people from across the country around their shared challenges. And then we have several 100,000 claims that we can look at to try and gain insights and improve practice, both locally and further out. to Ellen.
Yes, thank you. So, good afternoon. I want to spend just a moment on really the focus points for CRICO and how we manage our insurance program, which consists of a management company, 2 insurance companies, are very, very good insurance managers, both here and in Vermont. And the way in which we operate together really represents a philosophy that I think is important. So primarily what we do is, of course, liability insurance, med-mal, and general liability since the beginning. Over the years, we've added employment practices, directors and officers, errors and omissions, and we have found over time that employment practices, liability matters, connect over to the med-mal side of life more than we might have imagined, but it's another area of liability that we focus on and try to help our members be aware and manage themselves. And as Gretchen referenced, our patient safety program really began developing in earnest probably 20 years or so ago, and it moved out of loss prevention and a traditional insurance concept into really how do you get in front of it and how do we engage with the clinical leadership. And our board, of which Liz Mort, who will speak in a moment, is a member, is very intentionally and evenly spread among financial people and lawyers, but also with clinical leaders, and we have executives of the hospitals we insure, and we also have board members of the hospitals we insure. So we really make sure that we have that broad perspective, which helps in integrating being able to focus on patient safety in the clinical area as the best way to reduce long-term loss costs. I would say another aspect I would like to highlight about at CRICO, and I think it's pretty common for captives, but very different from the insurance world, is that on the claims handling side, our job is to defend the assets and the reputations of our insureds, and we never, ever settle for economic reasons. Cheaper to settle than it is to defend. If the medicine supports it, we will defend, and that's been an overriding philosophy for well, really since inception, and I think has paid off, again, in a long-term view. We really don't deal with a lot of frivolous claims because there's just no economic merit in trying to pursue them if you're on the plaintiff side of life. And then the last thing I might highlight here, and then I'll turn it over to Liz, is the partnership, and the partnership between the captive and the insured organizations and the leadership is essential in many, many levels, but certainly during the increase in acquisitions, and I'll come back to that in some comments later on, that partnership and trust levels between executives of the hospital organizations themselves and the captive is sort of key to what makes this tick, and being able to share not only confidential information, but sometimes less than pleasant information, and be trusting and collaborative in saying, okay, so what are we going to do about that now? So that's a very important element to highlight. The CRICO program, our CRICO community is our 10 shareholders. Partners is Mass General, the Brigham, and a number of other smaller hospitals in the area. A care group is Beth Israel Deaconess Medical Center and a variety of other hospitals that they own, and Mount Auburn Hospital, New England Baptist. The rest I think are fairly recognizable. Atrius Health is a physician system. There's no hospital associated with it. And then we do have 2 universities, and the oral history of CRICO is that MIT is in there to make sure that Harvard didn't take over. So they're there to counterbalance each other. And I'll turn it over to Liz to talk a little bit about Mass General.
Thank you, Ellen. And I'm so pleased to be here to share the story about Mass General and our journey in acquisitions. And I just want to acknowledge that as a chief quality officer at an academic medical center, it's the only place I've ever been a chief quality officer, but my relationship with CRICO and RMF has been incredibly important to my ability to do that work. I'm sure it could be done without that sort of a alignment and collaboration, but I think the point that Ellen just made about the trust and the transparency and the collaboration has been a really important aspect of my ability to do the work that I was hired to do at the hospital. But for today, let me just show you this. Our vital statistics are on the slide. We are an old academic medical center founded in 1811. We are a founding member of Partners Healthcare. As Ellen mentioned, the Brigham and Women's Hospital is the other large AMC, and we are located in Boston. We have about close to 50,000 inpatients every year, 1.5 million outpatient visits. The ambulatory environment is an emerging area of risk. It's the transfer of inpatient care to more ambulatory settings is an industry-wide phenomenon that has risks associated with it, obviously. We have a very busy emergency room, and we do a lot of procedures. Now, the MGH family, as we call it, is a growing group of institutions that relate. They're under the overall Partners umbrella, but they relate to MGH. So we consider those hospitals our family members. And in a few minutes, when we talk about how we view some of the services at Crico Strategies to help with our acquisitions, mergers, and alignments, I will be talking specifically about my role in working with those MGH family hospitals. And currently we have 4 affiliate hospitals in 2 states. Some of them are in Massachusetts, but we now have 1 hospital in New Hampshire. That's our most recent acquisition. And we have PSAs, or physician service agreements, in a number of institutions and across a couple of states. But I will be focused today primarily on the work associated with due diligence and acquiring hospitals in total. So I think I'll leave it there for the moment.
Thanks. So I'm going to kick off the next segment, which is really focused around 2 affiliations. They're rarely called acquisitions, by the way. I don't know why, but they're always called affiliations, regardless of the level of control that might exist post-affiliation. But so different perspectives on what we have encountered over the last 5 years. Certainly, everyone in this room is dealing with the level of acquisition activity in U.S. healthcare. So our experiences are not different from many of you. And so the things that we really want to look at from an insurance perspective and the insurer's view, and then as well as the hospital view. So some of the questions I think that we've really had to wrestle with and figure out how to make work better is really to look at, of course, what are the insurance and the underwriting impacts of an acquisition. And we, like many captives, we write our coverages in an overly broad manner because as a captive insurer, it's our job to say yes to, am I covered, as opposed to say no, which often may occur in the commercial environment. So when you're writing broad policy forms, you find yourself covering stuff that you didn't think about, and new acquisitions may bring new exposures that are exactly that, new. They're covered in the policy form because it's written as such, but if you don't know about them, they will surprise you at another time and date later, not of your own choosing. So that's important to understand what it is you're getting at a pretty deep level. And then how do you get at that? And what tools are available to do this. And there's a standard due diligence process, and M&A people and consultants advise our hospitals when they're looking at transactions and advise most others. But they're very quantitatively focused, and we have found they miss things. And med-mal seems sort of like a small line item somewhere that rounds off and doesn't really often catch the eye in a due diligence process so much until there's a claim, and sometimes the impact of a claim on a large claim can be surprising. And then really integrating the new organizations post-acquisition, and this would be true of any M&A type of activity. The easy part is getting the deal done. The hard part is now integrating the organizations post-deal. And in academic type organizations that are not known for their organizational hierarchy and command and control from the top, it can also be a bit of an additional challenge to integrate post-acquisition. So I'm going to switch it over to Gretchen to give you a couple perspectives on how we think about another element of risk evaluation.
Sure, thank you. So from the insurer's perspective, we have recognized through many different avenues the role that organizational vulnerabilities can play in a hospital or health system's ability to try and make patient safety changes. So specifically, when we reflect on our experience with our own insureds, or certainly with our client organizations, that despite an organization perhaps very accurately pinpointing exactly what their clinical challenges are, and despite really thinking through how to implement a patient safety intervention that's going to address that very specific risk, despite this effort, many organizations continue then to face the same issue that they're trying to prevent. And so as we reflect and work with our insured organizations that we know quite well, and reflect with our client organizations, what we realize is that there are these organizational vulnerabilities that seem to get in the way of that. And in a moment, I'll share with you our approach, CRICO's approach, to addressing, kind of sussing out what those vulnerabilities are and how we've come to address them. But as it relates to acquisitions, what we also have had experience with as we work with our shareholders that are growing through acquisition is that the same parallel holds true, is that despite, as Ellen mentioned, a very thorough and consistent due diligence process, there can be veiled risks, perhaps, that pop up either just after the deal is done, and they could be unexpected and certainly a very significant surprise, especially if you've just made a hefty purchase and a hefty strategic move. And so our hope as an organization was to really guide our shareholders in thinking about these challenges before the deal is done, so that there's a complementary perspective to the due diligence process and a complementary perspective to the data that tells us clinically what has gone wrong, so that we can help people have that additional perspective. And so we have, for several years now, conducted what we refer to as an adjunct risk assessment, insofar as someone who doesn't work within the organization but works within the captive can come into a shareholder organization and certainly identify clinical vulnerabilities through conversations with folks. That's, again, complementary to the data that we might have, but also these organizational vulnerabilities that limit the effectiveness of the programs that they're putting into place. And as we have now conducted these assessments in the acquisition space, we recognize that this is also a way to maximize the success not only of the acquisition process, but perhaps most importantly, the integration that happens after that. And so what we've developed and have been using over several years is what we call the RAP. It's a risk appraisal and planning process. So that's exactly what it is. It's our way of identifying what those organizational challenges are. If anyone was in the earlier sessions today and the reflection on the role of people in an organization, in the end it really comes down to that. And so this is our effort to appraise those risks that are very much in the human capital side of things, and then help an organization identify a plan for taking action. And so we've been refining this over time, but what we've found, a model that we found works quite well is this. So it's kind of 3 components, and they address issues of risk surveillance, risk mitigation, and then the last step of then prioritizing action, and specifically prioritizing efforts in integration. And so the 3 elements that we look at, and we do this through interviews, very intimate interviews, with a broad cross-section of an organization. So we often sometimes say kind of board to bedside, where we speak with a broad array of people and really looking for the same information from several different perspectives. So the first is that we want to help an organization, not only the individual organization, but perhaps the parent or family as well, understand how do you do risk surveillance? So what's the process like when someone recognizes that something has gone wrong or a near miss has occurred? Where does that information go? Who receives it? How do they assimilate it? What do they do with it? And where is it communicated? How is it communicated so someone 2 units over doesn't experience the same challenge that has happened where the event occurred? And we all know that process, and every organization will tell you that they are required to have a process for that type of surveillance, that type of monitoring and response. But there are certainly barriers that prevent that from working well. And sometimes it's role clarity, sometimes it's process clarity. But the other overlapping circle here is culture, which we all know, and it's one of those hard to define things, but you know it when you see it. And so in the process of these interviews, what we also try and understand is the role that culture plays in all of this. And so if there is not a sense of psychological safety, a sense of being able to raise one's hand when something goes wrong and feel as though they'll be treated justly and fairly in response to that issue, they're not, of course, going to follow the structure that has been set in place for them. And so we look to really understand this is a major component. I suppose the sizes of our circles could change a little bit. These are 3 equally important and overlapping circles, but culture trumps strategy every day of the week, and it can trump structure and leadership just as much. And then lastly, we evaluate the role of leadership. And this is leadership at all levels. So it could be a local manager, and it could be a senior level executive leader. It could be a board level voice. But what we're trying to understand is how accessible and visible are leaders that help empower those who are at the very front lines to understand that it's their job to raise their hand. They will be treated fairly and respected and rewarded for doing so. And so if those people are not accessible, not available, not visible, that's going to certainly limit the comfort and willingness to take those risks and raise those hands. And so from our perspective, having a structure for surveillance, having a culture that allows for that, allows then for you to identify those risks, take action, and be effective. All the data in the world won't tell you a lot if it can't follow the channels in an unhealthy organization. So locally, that has helped us identify for our individual organizations some real challenges to being effective with the interventions that we're advising that they adopt. But also, we recognize, my clicker's not working here anymore, I don't think. The role that this has also, there we go, in strategizing the next steps around acquisition. And so if an organization is bringing in a new affiliation or a full organization, recognizing these more veiled challenges that are harder to get at through the traditional due diligence process can help the parent organization prioritize what to do first. And so again, this is very much a culture-based tool, and it's also a qualitative tool. So we are, in order to gain the insights that we need to gain, the conversations have to be intimate, they have to be personal. We can't be perceived as someone who's coming in counting beans. And so
no offense to the bean counters
so
here.
sorry.
Okay, just saying. Sorry, didn't mean to interrupt.
Oh, no, it's fair. It's now I know how it feels, I guess, to be called a bean counter. This is why I'm so afraid of it. But so this is a very qualitative assessment. And so one of the points that we wanted to be sure to make was that qualitative information should not be underestimated. It cannot be discounted. And certainly in medicine, and certainly in finance, and certainly insurance, you all like the numbers, I get it. But the stories and the perspective and the insights that come from people's experience, the human experience, cannot be underestimated. And so this kind of adjunct interview-based assessment has yielded CRICO some really significant perspective on its own organizations and its growing family through the acquisition process. As I mentioned, it gives us a really in-depth cross-sectional view from both the front lines of care up to the senior levels. And what we recognize is that the perspectives, fairly and appropriately so, can be very different from one another depending on where you sit in the organization, but they all need to feel as though they're focused in the same direction. They all need to be rowing the same boat in the same direction. And oftentimes we recognize that there can be a little bit of a gap, an unhealthy gap in those two perspectives. And we also recognize that everyone is doing safety culture assessments, but this is what's underneath it. This is the why behind the data that our organizations are collecting. And lastly, it allows us, as I mentioned, to really prioritize the next steps that a parent, an acquiring organization may take, so that it gives a roadmap not only to address the clinical opportunities that have been uncovered in the due diligence process, but then the human priorities in terms of engaging staff and engaging leadership as you're then trying to evaluate how you take, as a parent organization, the next steps to create the patient safety framework that you need for your growing family, and from the insurer's perspective, managing the risks that come along with that. So I think it's my turn to hand it over back to Ellen.
So just a couple of concluding points and some critical risk factors, or success factors, I should say, that we think about, and then Liz is going to talk about Mass General's experience. And I think the 2 points we're highlighting here are really about collaboration and tools. We've talked a little bit about the tools, and I would say that where these things connect, and all kidding aside, there is an integration that is necessary between the qualitative and the quantitative, because neither gives you the appropriate picture in full. And figuring out how to do that is not easy. And I would also say part of what you'll hear Liz highlight is that it's taken us some time to both know that we needed to find a way to get better views before an acquisition closed into some of these issues, and to do so in a way that leverages the trust and the collaboration that you need to do that. Because pre-acquisition or affiliation, people want the deal to work. Who wants to air their dirty laundry before you've inked your deal? That doesn't seem like a really good idea. And so we've had to find ways to do exactly that, and have this not really be so much a go, no-go function as a what do I need to focus on first once I go? And if could be a no-go out of it, but mostly that's not the focus. And I think that has really helped us in getting information at the right time, and really being able to focus on areas that need attention earlier, sooner rather than later, and how do you prioritize. And with that, I think I will turn it to Liz and ask her to give us the hospital's perspective.
Thank you, Ellen. So what I'll do now in the next few minutes is really present a case study of recent experience in our acquisition space. And the first point on this slide, how do business development and hospital safety leaders collaborate through the acquisition process? I'll just say a few words on this one before I move into the case study. I was quite surprised when I benchmarked process with chief quality officers nationally, that in some cases they were quite independent of this process, and it was a network development executive or a marketing executive who was sort of working on this acquisition process for their institutions. And in our case, I have been working as the chief quality officer very collaboratively with my senior vice president partner in network development, and these issues are discussed as part of our routine management meetings. So we sit with the president, we all talk about what's going on, and we go hand in hand in exploring these opportunities. They may be out in the field first, looking at potential hospitals or programs. We get asked to look at various options and opportunities. But my role as a chief quality officer is very, very well integrated. But clearly that is not a uniform model in the industry. I would just make the point, having not experienced a process that doesn't include me, that for those of you out there who manage these processes, include your chief quality officer individuals, your safety individuals, at the beginning, just so you can plan prospectively, and also to develop a relationship. And I'll get back to why I think developing relationships with institutions that you're considering acquisitions, you can't start it early enough, because it's a very, very important fundamental piece of the framework, relationships and trust. We'll talk a little bit about the due diligence process, and I will give you 2 examples where the RAP process that Gretchen described has been incredibly important to our understanding of what's going on in the MGH family. And then I'll talk to you a little bit about how we're currently working on taking our family and developing a framework for sustaining, improving, growing, very aspirational, is to try to go from here to there in a place where all patients benefit. Okay, so the due diligence process. This is a dynamic process, and when I look back at how we did due diligence historically, and now how we're doing it now, and how I would do it next time, I think it gets better each time. And I would say when we've done due diligence historically, we did them the way you do them. And I think it's been through the work with CRICO that we've understood that this culture issue in particular is very, very important. Culture eats strategy for lunch, need to assess it. There is, as Ellen implied, and I think Gretchen did as well, there is a safety culture survey now that institutions do on a routine basis. In fact, the Joint Commission, who surveys hospitals on behalf of the Center for Medicare and Medicaid Services, the Joint Commission requires hospitals to periodically survey culture of safety. So there is a metric and a method to getting some data that you can put on a chart and look at your bar charts and your performance to give you some ideas about where your strengths and your opportunities are. So we have some tangible ways of describing and measuring culture, but I think complementing those measures with conversation that really gets at the board-to-bedside translation is an incredibly important aspect. Now, when do you leverage, or how do you leverage a deal to try to advance safety issues or improve quality in an institution? And I think some might say, well, don't sign the deal until you have it all cleaned up and everything is perfect and everything is operating the way you'd want to ideally, but it's not always possible, it's not always ideal. I think what's most important to do when you're about to sign something is understand what you have and what you don't have. Understand your organization's strengths and understand where their opportunities for improvement are, and make eye contact with that and have a process to longitudinally address it. But I think to force it in a go, no-go situation, unless it's a critical issue, a go, no-go decision should be made on a set of criteria that are important. But I'm not sure forcing gap-closing interventions at that time is the best thing if what you want to do in the long run is establish trust, relationship, and a framework for a go-forward process where you're really working as a system to improve patient safety. And I guess, the last comment here on this slide, it takes focus and sustained effort. It certainly does. Culture changes slowly, and that is at the foundation of patient safety. So a little bit more detail about our approach. There's the MGH Shield. And if you go to the MGH family institutions and you look at their signage, you look at their letterhead, there is the MGH Shield. And it's really my job to understand what the quality of care is behind those signages at the other institutions and drive it to the level that the shield would suggest is there when you open the door to get care at that institution. So anybody at the hospital looks at that shield and they have a sense for what that means, and my job is to sort of translate that. And we've developed a few guiding principles and hypotheses about this work. I fundamentally believe that when you build systems with large hospitals and medium-sized hospitals and smaller ones, ambulatory centers, rehab facilities, home care, hospice, I fundamentally believe if you design that healthcare delivery system correctly, that patient care in all sites, in the mothership as well as the acquired institutions, that healthcare and patient safety will improve in all sites. I do think that's very, very important. And even though the bigger institutions have sort of heft and bench and reputation, I have learned that and seen many, many small institutions with incredibly innovative, nimble, and flexible improvement systems, and we have bi-directional learning, and I think that is another important frameworking comment. I think you want to build that acknowledgement that it's not unidirectional, but that when you're building patient safety, it's bi-directional. Obviously, for community institutions, a clear benefit would be for patients to have access to the tertiary or quaternary care, innovation in healthcare delivery, and population health. So we've had meetings and committees to establish these sorts of guiding principles that really ask the question, why are we doing this? Where is the benefit in terms of patient care quality and safety? You could have other meetings about the strategic benefit, but Where is the benefit for patient safety? So the RAP that Gretchen so nicely described, I've had 2 recent experiences with how this RAP assessment has really helped me understand what's going on. And this one, the first one I'll give you, was really part of a routine process. The CRICO shareholders on a routine basis are entitled to a RAP. And at the time, the MGH family was growing, and it was suggested that we might use the RAP at that year to look at culture of safety at Mass General, but also at the MGH family. It was a phenomenally helpful experience. And I would say that the methods are, well, I think the methods have been reviewed, but what Gretchen and her team did is they came in and reviewed a whole lot of quality and safety data, our culture of safety surveys results, and then they had interviews. And they had interviews with chiefs, with physicians, with nurses, with groups of nurses, and board members, and it really was a board-to-bedside dive. And they did that at all the institutions in the family at the time. Then they reported back to each institution, and then centrally. And what I would say is that there were some very important take-homes for me, that some of the due diligence processes that we had had historically had missed that. The culture piece was really a bit of a blind spot. And understanding, in particular, what the frontline understanding is about leadership's views on quality and safety. Leadership is so important, and if leadership's views on quality and safety do not translate down to the providers providing care, you lose that. You lose that leadership strength and that advantage. So we did learn some things that we acted on pretty quickly to help assess where these gaps were in our institutions and how to help leadership be better communicators and address some of those issues. So without getting into a lot of detail, because I don't think the specifics are really that important, the message is, if you don't have a way to qualitatively assess culture to complement the safety culture data that all U.S. hospitals are collecting, you can easily miss things that are very, very important. Because the C-suite doesn't take care of patients. Well, some of us do, actually. I still practice. But in general, the C-suite doesn't take care of patients. It's the front lines. So that's why I think the RAP process, when we looked in the rearview mirror about what we already had acquired, was very, very helpful. So moving on to the next example. Oh, I should say, maybe just to give you a little bit more detail, the kinds of findings, in addition to looking at the MGH Family Hospital, were very concrete. I mean, there were very specific suggestions that were given to me. And Gretchen and her colleagues said to me, as well as the president of the hospital, you know, we think that you have a very good model for quality and safety management in your AMC. What's the translation of that in the communities? It wasn't a prescriptive set of recommendations, but more think about what would be the community hospital appropriate model for developing that kind of a hub and spokes model that we have in the institution. For example, we have department quality chairs. Every chief identifies a physician who devotes between 0.1 and 0.5% FTE related to quality and safety. Well, how would that translate into a community hospital? It's an important aspect of a quality and safety program, but how does that translate? And then the culture of safety issues were brought up. So we realized then, when we were working on another acquisition, that, boy, let's remember what we learned when we had the RAP, and let's add that to our acquisition due diligence process. So and also we thought, well, should we try to do it ourselves? Should my team, because my team at Mass General does quite a bit of quality and safety consulting, should we try to do that? And then I realized, no. Because as we were developing this plan to acquire a hospital, we were developing relationships and trust. And it was much better, actually, for Gretchen to do it, because it was a third party. Related, obviously, CRICO and Mass General were related, but to have somebody else come in and dig into these issues in interviews, talking to all sorts of folks, it was actually quite easy to do. Obviously, we have the protocol and that set up, but the advantage of me not having to do it, or my team, was obviously the relationship issue. And I would say the findings reinforced our due diligence process, and they served, in this case, the findings from the RAP, in this case, served as a validation process. Clearly, we were more tuned into culture. We looked more carefully at the safety culture data, and we did a lot of talking and relationship building. But ourselves, but in addition, the RAP was an incredibly important validation process. And we did have some suggestions to the management team, and I went when Gretchen reported out to this hospital. It was very, very well received. Everybody was grateful for the feedback and the suggestions, and I thought it was very, very well worth doing. So just a little bit more about what we're doing to build that framework in a go-forward way. We have now the family with the 4 institutions and the MGH AMC, and we've started some things immediately, the kinds of things you would expect, looking at serious reportable events and being there to, if someone needed help on a particular issue. And we've been building, for the last year and a half, relationships. And we've been building a coalition. And I would say this, again, is very, very important, because if you were just to superimpose a framework, superimpose an org chart, start setting up meetings, people are coming to the table not quite sure about who you are and whether they can trust you. But if you give some people some time to get to know one another and give an opportunity to be helpful. So a hospital has a problem, they have an adverse event, they have a case. They pick up the phone and they say, Liz, can you help us with this? And I say, of course, tell me what happened, how did it happen, et cetera. And we start building a program. They are now grateful. They realize that we will treat them justly and fairly and that we genuinely want to help. And I think that period of time where we just spent some time getting to know each other in our institutions was very important in setting up the framework. And now we are doing that, we're developing that framework with more specificity. Another set of tools that I want to mention that I think is very exciting, many of you may know Atul Gawande, a physician at the Brigham and Women's Hospital, a writer in the New Yorker, and written many very important books about patient safety. He's also been working on developing tools. So these tools are designed to look at patient safety structures and processes in general, but also in the high-risk areas, the areas that we run into trouble with, OB, emergency medicine, and surgery. These are kind of your high-stakes patient safety areas in any hospital. But what Atul has added to the set of tools that are existing now through CRICO strategies are these discussion guides that quality and safety leaders can take into an organization and talk about, well, how does your OB program work? Do you have these protocols? What about your emergency medicine? How about your surgical areas? So again, this will once again make the due diligence process even more robust, or to use in a go-forward way to set up a program. So over the summer, this past summer, this was the poster from MGH Family Quality and Safety Retreat that we held on June 23rd. And this was after a good year and a half of discussion and building a framework and building relationships. We are now establishing a family-wide quality and safety council, and this is kind of a word cloud of some of the feedback that we got from the group on that day when we were asking them, what should we be doing? What should a quality and safety framework across the MGH family be? And you can see the words. We should share services and best practice, network, right care, right place, shared vision and goals, technology, and basic needs. So I guess I would say, to summarize the hospital's perspective, I think it's very important to integrate business development and patient safety efforts. These due diligence processes, as I mentioned, are evolving, and our next one will be better than our last one, and our last one was better than the ones before. So keep your eyes and ears open for new tools. Don't be too forceful in your go, no-go decisions. Obviously, don't be wise about what you decide to do. But if you push things too hard and too fast, you may erode a relationship that hasn't even developed. And I think leveraging the external assessments is important, as we mentioned, and then developing the structure for ongoing collaboration. And this last comment, I think, sort of summarizes it well. We assess things, we reassess things, we rinse, and then we repeat. This is a very, very dynamic and ongoing process, so I'll stop there.
Great. So thank you. We went a few minutes longer than we expected we might. So we're going to just open it up now to questions, comments from the audience. Happy to, right up here.
When you're about to make an acquisition, do you first prep them with telling them that the quality procedure is going to be this? So in that transition, they're not surprised, they're not PO, they're not, how do you do that?
Sure. So just very quickly, when we're going forward with an acquisition, how do you prepare the acquiring organization in terms of expectation setting for what's to come?
I think it's a rolling set of expectations. That's why it's important to get your quality leaders and your development leaders together. So you just start talking about it, and then the process rolls out. And I think you need to be very transparent about it and give people a heads up about what's coming.
Do you have a pre-prepared plan of transition?
Well, the transition plan is developed collaboratively. I mean, that's really part of it, collaboration, trust building, goodwill. You want people to trust you. You want people to say, gosh, I have a problem, or I'm looking around the corner and I'm worried about X, Y, or Z. I can't emphasize that enough. But yes, we have a plan, and we might put it out as a straw person plan and then get their input.
Yep, in the back? Oh, right there. No, in the middle. I suppose you're the middle.
Man in the middle.
The man in the middle.
Good job. So I just want to make sure I put this in perspective. So I would assume Mass General or Partners has a captive for their GL, DL, maybe
That would be us.
Yeah.
Crico?
Okay, that is captive, right? And so before you bring in an acquisition or affiliate, you look at their culture much like you look at the financial valuation, liabilities and assets. So my question, Liz, is have you ever looked at an institution, you know, in your due diligence and said, they don't have the right culture, they don't get it, they don't understand safety? Or is it just a way for you to assess, hey, we can make this work and we got a lot of work to do? How do you use that?
I think in my experience, we have not gotten far enough along where one of these processes, the RAP, has led to a no-go decision. I think there's a lot of intelligence that you can get about an organization that's publicly available, so that we're quite smart about that before we get too far along in our conversations. But
Is the reverse ever true, though? If you're looking at an institution and said, boy, this is really, you know, they have very low GL, EL, and this is really good stuff. Has it increased the value of an institution?
more, I don't know about increase the value, but it validates and reinforces, it accelerates the process when you start seeing this information. And CRICO does a good bit of its own due diligence as well, particularly looking at the malpractice experience, that we all, you know, there's a bit of a triangulation there. But absolutely, I think when you see a positive or a healthy organization, that reinforces the movement towards togetherness.
I might just add one other perspective here around that, which is, you know, the RAP itself is a pretty time-intensive, labor-intensive, deep dive. And you can't always do that early on in your process. And so there are ways that we're integrating patient safety and quality data in our underwriting process and within the insurer, so that we can give a sort of a flash read earlier on to say, do I have a serious problem or not? And mostly in the acquisition environments we're all in, it's going to be rare you're going to have a reason not to close a deal because everyone's trying to get their market share and so forth. It more has to do with where should I focus first? When this becomes my problem, where do I pay attention first? And that's its biggest value.
And as experts in patient safety, how would you rate the reliability of leapfrog, A, B, C, or D?
I can talk to you after in the break if you want. I'm pretty sure.
There's a question, yeah, in red. culture can get in the way of a lot of things, but I think that what Ellen was just saying is that it may not be the decision maker in terms of a go or no go. It can get in the way of a lot of things. It may not, in the end, get in the way of a go versus no go, but it certainly gives the parent organization a sense of what you've got to do first. And it may mean that the clinical risks that you see, your efforts to address them as the parent organization may not be effective if you have these cultural or leadership challenges that may supersede your ability to be effective there.
I would also add, just from a financial point of view, I can't say the culture is more dominant than economics. If
Right.
the hospital's losing money, and a lot of it, you have a whole range of challenges, inclusive of culture. But not understanding cultural differences and potential cultural issues, understanding between the front line and the C-suite and so forth, can cost you money that you did not
Right.
think you had to spend. And we have seen many of our organizations bear costs that they did not anticipate. And usually that doesn't make people too happy.
Okay, I don't want to stifle debate, but we've run over time, so if you could show your appreciation to today's panel, I'd really appreciate it.